Hello, everyone. Hi again, Dr. Clark.
Hello, how are you?
Great. That is an amazing color combo.
Oh, thank you.
I love it. I know we have a few attendees right now.
Mhm.
It's good to see you all. We are recording. So let's go ahead and get started because I know we have a lot to cover today. Um,
Always.
we- as always, I know, always so much to learn. The number of times I go back to our notes after I've had a webinar and I'm trying to figure out something for a patient, I'm like, let me go back to the webinar notes and see what I wrote down. It's always so much learning, and I appreciate it. Good evening to everyone who's joining us for our Seven Starling webinar series. The series is designed to give you healthcare providers across specialties pearls to help you feel more confident in supporting your patients with mood and anxiety disorders across the reproductive lifespan. I am, for those of you who might not know me, I'm Dr. Nazanin Homofar. I'm a board certified OB-GYN practicing in Northern Virginia and the medical director at Seven Starling. Seven Starling is a virtual mental health clinic that treats those experiencing anxiety, depression, and trauma throughout fertility challenges, pregnancy loss and miscarriage, abortion, and postpartum. And as always, I'm honored and thrilled to be joined by Dr. Crystal Clark, who is an associate professor of psychiatry at the University of Toronto and associate head of research at Women's College Hospital. She has dedicated her career to reproductive psychiatry and the advancement of maternal mental health as a researcher, educator, clinician, and thought leader, and also an advisor to Seven Starling. Today, we're talking about what every reproductive psychiatrist wants the front line to know. So, welcome, Dr. Clark.
Thanks for having me as always.
It's great to see you. I know as a reproductive psychiatrist, you are deeply familiar with women's mental health. And this webinar series, you and I have explored and gone deep into certain topics. Last 2 months ago, we talked about SSRIs and some of your go-tos and how we can think of as OB-GYNs titrating those medications for patients. During today's talk, we'd love for you to share some of the most important takeaways you'd like OB-GYNs and other providers, other women's health providers to know about women's mental health.
All right, sounds good.
Let's jump in.
Yeah,
Let's start with, most of the, we focus a lot about on perinatal mood and anxiety disorders. Let's start with that. Who is at risk for perinatal mood and anxiety disorders specifically?
yeah. So great question. In terms of risk factors, which I will start by saying to everyone, especially anyone that might have some experience in this area, we need to learn more, and I hope that, and I'll explain why. But what we do know is that every birthing person is at risk globally. 1 in 5 will develop a mood or anxiety disorder in the perinatal period, especially postpartum. But we know that there are other, groups that are even at more risk. So those of lower socioeconomic status, for instance, have a greater risk, 40 to 60% greater risk compared to, the typical 14 to 20% risk for a perinatal mood or anxiety disorder in those of higher socioeconomic status. We also know that race and ethnicity can impact the risk factors, the risk for this for episodes to onset or recur during pregnancy and postpartum. So when we think about Black populations as well as Hispanic populations, they are at greater risk. The estimates of how much greater the risk is for racialized minorities is not actually quite that clear. Some would say as much as triple the risk in the Black population, but there are some inherent flaws, I would say, in those studies in terms of we haven't done a great job of looking at social determinants of health and just what might be driving that risk besides race and ethnicity.
Triple the risk. I want to talk about health disparities in a little bit, but that's really profound.
Yeah.
Um, what would you say in terms of um, you went through the prevalence a little bit, those risk
Mhm.
factors. What are, I think we focus a lot on depression and anxiety during this time period, what other perinatal mood disorders should be aware of when we're thinking about pregnancy and postpartum? And can you tell us about the screening and the chance of recurrence for those?
Yeah, so I wanted to highlight a couple of things too that I forgot to mention in terms of risk factors. So, of course, anyone treating someone during the perinatal period, don't forget to ask about, like, have you ever had a mood disorder or any anxiety disorder or any mental health problem? Because those patients are at higher risk for having something unset in pregnancy, having a family member with, especially a mom or a sister with a history of postpartum or a mood disorder in pregnancy would also increase the risk. But other disorders, to your question, other disorders that we need to be thinking about or other experiences, trauma is huge. And that is something that we have been giving more attention to, but have so much more work to do to better understand how trauma is impacting the perinatal experience and also comorbid with anxiety and other mood disorders. So trauma is something we're screening more for and talking more with our patients about so that we can address that in the perinatal period as well. Other disorders, of course, bipolar disorder. So those of you
Your
who are
specialty, your
yeah, those
area of
joining us tonight,
expertise.
that's one of my areas of expertise, and I can't say enough about the need to really screen for it in this perinatal period where this population is way more vulnerable to a recurrent episode, and it may present as depression. It may present as some, anxiety that at least initially. So it's so important to be looking out for it. These patients have a higher risk of having postpartum depression as well as having postpartum psychosis.
And you've mentioned this to us in the past, but just briefly for some of our viewers who might not have heard it, what are a few ways that we could screen for bipolar without just specifically saying, do you have a history of bipolar disorder?
Yeah, I definitely think asking, because sometimes people don't tell their docs outside of the mental health provider. So if they're not talking to their psychologist or psychiatrist, I think sometimes they might keep that to themselves. So even just asking or asking what medications, if any, they're taking for mental health might give you a clue. Because sometimes I've found that their treating psychiatrist may not tell them either. So they may just call it mood disorder, but they're taking lithium or quetiapine or something that's like may make you suspicious for bipolar disorder. But in addition to that, I would say the mood disorder questionnaire is a good one that can be used to do an initial screening. That's a self-report screen. And it can also be used to, just kind of repeat screening. Like I like to use it not only to screen, but as a way to educate my patients about symptoms that they should look out for. And then if someone does have the disorder, it could also be used as a way to track symptoms over time.
The mood questionnaire.
Mood disorder questionnaire, so
Yes.
also known as the MDQ.
Okay, great. The MDQ. Um, I think that just wanted to go back to what you said about asking people. I think I have found so many times that what people fill out in their medical history, or when my medical assistant goes through the history, it's
Mhm.
very rare for that. I have to actually specifically call out, have you ever had a mood disorder or anything like anxiety or depression or bipolar disorder? And then there's oh, like there was this time in college, and then I inquire a little bit about how did you seek help? Did you see a therapist? Were you ever on any medication? And oftentimes, especially in pregnancy, people are like, oh no, I was fine. I just did some therapy. But really calling out and letting them know that they're at increased risk. And so we're going to follow their mood very carefully. And I want to make sure we prioritize that, I think has been really helpful in alerting people. So many times we've talked about this, people think of pregnancy as being in a bubble. Like
Yeah,
whatever happens in the pregnancy or whatever happened before doesn't quite affect the rest. And
exactly.
helping educate people on the potential, long-term effects, I think is really helpful.
I think it's so critical. And before you go on, I would just add, we'd be amazed at what our patients interpret or how they frame things in their mind. So it's so important to ask very direct questions and give maybe examples sometime. Just if I could just briefly give an example.
Please.
Um, on the flip side, as I ask patients about pregnancy, it's amazing how many people don't think a pregnancy that ended in a miscarriage or a termination was a pregnancy. So they'll be like, oh, this one pregnancy. I'll ask, well, any miscarriages? Oh yeah, I had 2 miscarriages. Any terminations? Oh yeah, I had 1 abortion. I was like, so 4 pregnancies? It's like,
Yeah.
I think of it the same with our mental health questions. We have to be a little more direct. People, they just frame it differently in their minds, or they might be feeling shame about it. So
Absolutely. I think that's a great point. Um, you spoke a little bit about bipolar disorder and you mentioned the postpartum psychosis at the end. Just briefly, can you tell us about um, how many people are impacted by postpartum psychosis and what it is?
yeah, so postpartum psychosis is one of the few psychiatric emergencies. It is more common in patients who have some underlying bipolar disorder or have a history of bipolar disorder. It affects 1 to 2 out of 1,000 patients who will give birth, and it onsets within the first month postpartum. It's a pretty rapid onset. It is, it's different than just your like looking schizophrenic, so to speak, and the kind of delusions that someone is maybe patients talking to themselves, hearing voices, or um, TV's telling them what to do. It doesn't present in that kind of classic psychotic way. It's more, and many times more subtle. The delusions might be altruistic, um, or more so the actions might be altruistic. This is what we see infanticide. So the delusion might be that the baby is has a terminal illness, and I must save the baby from this terminal illness by freeing them from this world. So they might take it upon themselves to take the life of the baby in an altruistic manner to save them. Um,
Mhm.
but it can present in a very much so cognitive changes where the patient just doesn't seem quite with it. You might, this is most obvious in someone who was high functioning prior to pregnancy and prior to postpartum, where their judgment seems off, they're not thinking clearly, um, they just seem a little out of it. That's most alarming for me, actually, and it's somewhat subtle. It's easy to dismiss it as I'm tired or they're tired,
Mhm.
for the patient to rationalize. But the delusions, which they may not readily share, are the most significant feature about it as well.
And I'll point out to everyone, we did do a webinar specifically on postpartum psychosis. So if you go on YouTube and search for Seven Starling, you'll be able to find that to learn a little bit more. I think the other important thing to call out is something that you've brought up with me before too, is suicide. And
Mhm.
it's incredibly chilling to see the headlines that suicide was the leading cause of death in the first year postpartum.
Yeah.
What can you tell us a little bit more about what we know about suicide in this time frame?
Yeah. So mostly that it is the highest incidence is in the 9th through 12th month, in that first postpartum year. And which I think most people don't think about it because they're like, well, why not the first 3 months? And the 9th to 12th month, if you think about it, not that we fully understand why it's that time, but I think there are some theories at least that we can consider, and that the 9th through 12th month is when no one else is really paying attention anymore. They're not seeing their OB. They may have been trying to fight through whatever they've been experiencing, trying to like just hold on, thinking it's going to get better, but it's been progressing. Um,
Mhm.
they may not have reached out for help at this point or even realize that they need help. It's just kind of progressed, it's more severe. And they might not, just might not be in touch with anyone. Family is not, family is usually descending upon families early in the postpartum period.
Right.
The 12th month, people aren't around as much. Um, so definitely lots of theories as to why it might be that late in the first postpartum year, but it's going untreated, unrecognized, unaddressed in so many cases. Many that we never even hear about.
Yeah.
So yeah, it's really unfortunate.
I I think one thing I've taken away from you and our conversations is a reminder at that postpartum visit that perinatal mood and anxiety disorders extends far out from that 3 month, that definitely that 6 week mark, but also that 3 month mark. So, one thing I have started saying, really because of my learning from you, is being very intentional in telling my patients at that 6 week postpartum visit, even if their screen was negative, I'm so reassured that your screen was negative, but I want you to know that perinatal mood and anxiety disorders can affect you up to 1 to 2 years postpartum. So if you notice, especially with a lot of my patients when they're going back to work, that transition, juggling, having to juggle so much at home, maybe at work, with identity and relationships, that if they find that things are changing, if they don't like the way they're feeling, to please reach out, because we would want to make sure we address it.
Absolutely.
Do you have any other tips for what people might say, or how we might, do you ever call out that risk of suicide to patients, or do you find that that could potentially scare them more?
I'm okay if it scares them, because we want them to act and not take it for granted. Um, but yeah, absolutely. I consider that a part of the education, and I think it's so important to do that education, even in someone who you give the EPDS or the PHQ-9 or even the mood disorder questionnaire and they're fine. That's an opportunity to educate and say that, hey, just in case something happens, here are some resources. It might be 3 months, 4 months, 5 months, because you have to remember that number one, everyone may not have had anything happen by 6 weeks, and hopefully nothing does happen if that's the case. But something could happen at 3 months and 6 months. That's why I follow people a year out, and
Mhm.
and it's good for them to know more about that. But also, at 6 weeks, they might be experiencing something that they have yet to fully have insight about or fully be willing to accept. So they might still be trying to be like, no, I'm not. I'm good.
Mhm.
I'm okay. No, if I just hold on, and they're
Yeah.
just not ready to endorse. So yes, I want to tell them this is the risk factors. This is why it's important. And again, not just highlighting that suicide is a risk factor, but the development of their child is a huge risk factor. Having delayed development or having social delays and things like that is a major risk factor for untreated depression and anxiety in the mother. So it's a risk factor to their child, and they need to understand that. And that scares some patients, and I'm glad it does, because I'm like, we have plenty of data that is showing the impact, despite their best intentions, it is very
Yeah.
impactful on the growing infant.
Yeah, I have, I understand why that would help someone a little bit more, because I think during
Mhm.
this phase of your life, you're so used to giving yourself and making sure everyone
Mhm.
else is okay, even though we
Yeah.
know that analogy, the metaphor of the oxygen mask, but um, it sometimes resonates a little bit more.
Yeah, and I think that's so important, because I find that most mothers, parents are focused on, their children, and they would sacrifice themselves. But I have to remind them that actually, and not caring for yourself, you're actually impacting your child.
Yeah. How about in pregnancy? What are some of the other implications of untreated perinatal mental illness?
Yeah. So we also know that the outcomes in pregnancy, independent of pharmacotherapy, are um, can be significantly negative, actually, for untreated mental illness and anxiety. So mood disorders and anxiety. So uh, preeclampsia, preterm birth, low for gestational age babies and low weight for gestational age babies. And this that's a problem, especially in the Black community where preterm birth, for example, is one of the
Much
leading causes
higher.
of infant mortality and it's much higher. So that's huge. Of course, behavior is a concern if there's an untreated mental illness, such as not going in for prenatal care, self-medicating with substances, when
Mhm.
otherwise might not if they were well, having, just poor judgment, um, things like that.
I don't think I've ever, when I give my little spiel, I don't think I've ever been intentional about linking it to these other conditions that you mentioned. So I think that's also just giving people a sense of how much it's related to other conditions that we follow in pregnancy is so important. Um,
Yeah, I try to tell people that it's not, the brain is attached to the rest of the body. If this was any other organ, we would not question like, oh, the heart not working right affects the kidneys and the lungs. What I mean,
yeah,
the kidneys not working right, affects the lungs and the heart, it just like, so the brain is similar. We don't question that when we talk about a stroke or Parkinson's or anything, but mental health just is less tangible in that way. But the cortisol, the impact on, um, just the stress hormones and other cascade effects from the HPA axis affects the uterus. So it's not an
yeah.
isolated, incident to the brain.
That's one of the Dr. Clarkisms I'm going to borrow. Sorry, I was typing it out because I think that's there's some phrases you borrow from your colleagues that are just like that get to the point. I like to tell people that they don't need a yearly pap smear and that they're more than just their pap smears. Like
Right.
preventative care visits are much more than just getting a pap smear. So this is one of them. The brain is attached to the rest of the body. I like that. I know initially, at the beginning, you talked about the health disparities in prevalence and screening of mood disorders. You were saying that the Black perinatal population has like 3 times the risk of triple the rate of depression compared to the white perinatal population. What else do we know about the impact of these mental health disparity, the mental health on racial disparities?
Yeah. So, well, we know that we need to know more and that we really need to better understand this in terms of social determinants of health. The issue with the data that estimates triple the rate, for instance, has mostly been done in low socioeconomic um, Black populations, which clearly does not speak to the entire
Yeah.
heterogeneity of the Black community. So I think we've got to better understand, but there are definitely some studies that suggest that regardless of socioeconomic status, there's still a higher risk. We're still trying to understand, why that may be. Some would definitely suggest that racism and ongoing discrimination is part of that picture, just the weathering of that. But might there be other social determinants of health that are impacting outcomes during the perinatal period, especially when historically there has been suggestions that actually Black women, for instance, do not have higher rates of depression compared to their white counterparts outside of the perinatal period. And we need some more data on that as well to see where things are in the current time where more people are getting screened and seeking help and we're starting to break down some of that stigma because it's very possible that studies back then they couldn't find people who would participate. So who knows? So I say all that to say we have so much more we need to do to understand disparities, but definitely research that has been done at least and for those who are low or social economic status, definitely, which is a risk factor in itself, have definitely shown that there's a disparity. Um, we need to compare that to other low socioeconomic white counterparts to better understand, like, is it exactly the same if their counterparts are, of different backgrounds, but same
Mhm.
socioeconomic status, or is there something else driving a disparity, with direct comparison?
Would you do anything differently for screening in the population? with this data?
Um, so data suggests that, for example, patients with a EPDS who are Black will have lower scores, but that are still indicative of a depressive episode. So our usual 10 to 12 may not really capture them. And that could be because that's just not the language they use for some of the questions, that we use on that scale. They may underrate their symptoms. So it's important to, I would say if they're scoring even a 6, to just ask more information.
Got
Um,
it.
how are those symptoms affecting their day-to-day life?
I mean, I think that's a really important call out
Mhm.
and a very um, tangible thing our providers can do and know because and just to reiterate what you're saying is that based on the studies that show that the EPDS scores are going to be lower for Black patients with perinatal mood and anxiety disorders, we should still be flagging if someone is at a 6 to 7.
Yeah. I think you have to know what that means for the patient. And I've had this happen in patients of different backgrounds where I give them a screen and it's like their baseline is a 0, which most people's baseline is not 0. We always like check something, a few things,
Yeah.
some things that we're having day to day, so we might be at a 3 or a 5 baseline. But I have patients where it's like, no, 0, 1, that's what they consider their baseline to be. But when they're not feeling well, they're at a 5 or a 6. And I think, we really have to personalize this a little bit more. Clearly, someone scoring above a 12, we're concerned, but we need to ask more questions for those who are not scoring high, just to make sure that we're not missing anything.
Thank you. I know we have just a few minutes left, and I wanted to touch on medication safety. And if you heard knocking, my children just came home and they're not, they like slipped something under the door that I'll have to look at later, but hopefully they won't keep knocking. What, let's talk briefly about medication management. We have had several webinars on it before, but how do you counsel providers on how to discuss medication safety and dosing with patients?
Yeah. So, I first start by saying if they're taking something that's already working for them, please let them continue taking it. There's few drugs that we would absolutely say change, and even some of that might be case by case, but Depakote would be one where they just shouldn't be on at all
Okay.
without some clear reason. If they're of a childbearing age. So if they come in pregnant on that this early in the first trimester or something, or in the first trimester, you might try to get them off. Um, but for the most part, there aren't many things that are absolutely contraindicated. So if they're taking it, it's effective. You definitely want to discuss with them what the risks and benefits may be of that medication, continued exposure. But in most cases, I would leave them on what's working most effective for them. Uh,
Great.
yeah.
I think, and then how about starting? You've
Yeah,
briefly told us before, like how to talk to patients about starting it, but can you
yeah,
share with this group?
yeah. So I talk to patients in terms of like functionality, how much time it may take. Clearly, if they're having mild symptoms and even sometimes moderate symptoms, they can go seek therapy, and if they have therapy accessible to them. But moderate severe to severe symptoms, those symptoms may not get better with therapy, and they may suffer longer trying to get better with therapy. So getting back to their well-being, but also their child's well-being, and that time they're missing out in terms of bonding with their child because they're not feeling their best. I'm telling them like, how long do you want to suffer, in silence here? And, you know, if they're pregnant, we have many options, SSRIs in particular, that are not at risk for congenital malformations, and others. Some of those same ones are great in breastfeeding. They're low transfer, so we have options.
Great. Well, I know we're at 6, but for our attendees, if anyone has a question, we can take 1 or 2 questions maybe before we hop off. I'll give you all a few seconds. I'm seeing one of my coworkers on here, which is always really nice. Okay. If no one has a question, we'll keep it at time. I think, Dr. Clark, thank you so much for always being generous with your time and with your knowledge and helping us improve on the front line how we start talking about mental health, women's mental health with our patients before we send them to you.
Okay.
Um,
Yeah, absolutely.
so thank you for that. And to the providers who joined us today, we hope you found these 30 minutes engaging and informative. Just a reminder that Seven Starling, we're seeing patients in Texas, Virginia, Maryland, DC, Nevada, New York, Pennsylvania, and now North Carolina. So we're expanding our reach. We also accept many insurances, and you can always message us at practices@sevenstarling.com. We are committed to providing the full spectrum of women's mental health care at Seven Starling, and would love to your support. Would love to support you and your patients. We will send out a link to this webinar at our next newsletter. And if you ever have any questions or any topics that you want us to cover, please feel free to send them my way, Nazanin@sevenstarling.com. Dr. Clark, thank you very much again.
Thanks for having me.
Absolutely. Have a wonderful rest of your week.
All right, you too. Take care.
Bye.
Bye.